Coffee with Coker, a healthcare business podcast published by the Coker Group. I'm your host, Mark Reibel. This is Coffee with Coker, episode 2. The initial episode that we had published is our first episode. Hopefully that was helpful for our listeners, where we provided a little bit of background and context as to what we're trying to do. And with the podcast and the content that we're putting out, just real briefly as we intro into this episode, just for background, Coker Group, we're a national healthcare consulting firm, and we work with healthcare organizations all over the U.S., as we have for over 30 years. And we help with successfully navigating changes and challenges of the ever-evolving healthcare industry. The podcast here is just an opportunity for us to talk with members of the Coker team and get insights from their experience, and also outside guests that allow us to talk about the issues that relate to healthcare organizations. And particularly, we're talking to healthcare services, whether it's a hospital or health system or a physician-owned group, private practice, or everything and anything in between, as well as those organizations that provide services to healthcare services companies. So this is an opportunity for us to dive into content, and that's exactly what we want to do here on the second episode. So with that, I'm excited to introduce our guest today, Dr. Mac Knight. I'll just briefly intro him, but I'm going to have him talk a little bit more about his background. But Dr. Knight is a member of our senior leadership team here at Coker. He's a senior vice president here, as well as our chief medical officer. And Dr. Knight covers a lot of different things for Coker, but one of his specialty areas, I would say, he's absolutely a expert and respected expert on the area that I broadly refer to as the volume to value shift in our healthcare industry right now that we're seeing and will continue to see. Today, we're going to talk about that at kind of a high level, but it's an opportunity for us to tee up some more specific parts of that discussion, because there are a lot of different pieces, and we can drill down on future episodes later. So this is going to be a series on value-based healthcare and the volume to value shift. And with that, Dr. Knight, welcome.
Thank you. Glad to be here.
Why don't we just start out? Tell us a little bit about kind of brief background, and also kind of what you spend your time doing the most of here at Coker.
Sure, be glad to. So I'm a internist, hospitalist by clinical training. And about halfway through my career, Mark, I got more and more onto the administrative side of healthcare delivery. I went back to got a business degree and had a number of physician executive roles with a large healthcare system in South Carolina. In fact, that's how I met the Coker Group. I was one of their clients, and when I really decided, as my wife likes to say, to go off the deep end and become a healthcare consultant, I contacted Coker Group, and thankfully they took me on board. So I've been with the firm now for about 5 years, and hopefully it brought some value to the work that we do.
We're glad you joined the dark side.
Absolutely. Absolutely.
Good. No, that's helpful. I personally, I've enjoyed our conversations over the past few years, because understanding what's happening with the evolving landscape within the industry, that means a lot of different things, or there's a lot to that, I guess. Understanding kind of some of these, how some of these high level developments and changes and policies are ultimately affecting how services, organizations, and providers are functioning on a day-to-day basis is ultimately, I think that's really at the core of what we do. I know that's a core of kind of where you've developed so much of your specialty and applying your experience. And with that, we're talking about value-based healthcare or value-based reimbursement, although the discussion is certainly more than just reimbursement. But I think we're talking about a very, what I call this volume to value. And actually, I shouldn't claim that, because I completely stole that from you, but the shift from the model the fundamental model our system, healthcare system, operates, going from a volume fee-for-service based model to something that is much more value based, and what is entailed in that. And so maybe just start out by kind of giving us that high level description of what value based healthcare, value based reimbursement, volume to value is.
Sure. So I like to actually back up a little bit and describe or define the term value. There's probably 100 definitions of value if you look in the dictionary. But the one I think is most pertinent and relevant to healthcare is value being equivalent to quality per unit of cost. So if you think of that and you think of the consumer of healthcare services, they want obviously good clinical quality outcomes. They want a high quality patient experience, but they also want that at a reasonable cost. And to me, the overarching imperative in healthcare delivery today is how do we provide those two things concurrently? We got pretty good back in the 80s and 90s in terms of lowering costs through heavily managed care, but quite honestly, quality suffered a lot during that experiment, and consumers were unhappy. Actually, as a primary care gatekeeper during that time, I was unhappy, as were a lot of my professional colleagues, because to control costs, we were just having to say no all the time. No, you don't need that test. No, you don't need that hospital admission. No, you don't need that prescription. And eventually we pushed that no to the point that patients were actually being harmed. We've all heard about things like drive-by deliveries and really, really short lengths of stay for things like mastectomies. And that really gave that kind of experiment in, call it what you want, capitated managed care, HMOs, a bad name. So
I take it the patient shouldn't be a secondary factor as it relates to how physicians and providers ultimately deliver care.
Well, I think that the trick is, again, how do you lower cost while maintaining or hopefully even improving quality of care? And that's what it's all about today with the volume to value shift. So we want to increase quality and we want to decrease cost. And if you look at value again as quality over cost, then you increase quality, you lower cost, and you end up with higher value. And that's what the whole volume to value shift is. My whole professional lifetime, we have basically delivered healthcare services on a fee-for-service basis. Whatever we did, office visits, surgeries, procedures, all kinds of hospital admissions, other types of healthcare services, everything was billed out on, you gave the service and then you got paid for it. Nowadays, you give the service, but there are performance measures, both quality and cost measures, that have to be reported along with that. And if you don't produce high quality and lower cost, then you don't get paid.
I like when you talk about the value piece and defining value, and I agree, that is the best place to start. You know, I'm a finance guy by nature, I guess, and value certainly means something or kind of insinuates something from an economic or financial standpoint, but that piece, fitting that piece in about the quality is something that is very unique, obviously, to our industry, but has also been, obviously, was joking earlier when I said the patient and, you know, what's the primary versus secondary driver in terms of how care is provided. But there has been a disconnect, it seems, in the past, whether it's the way, whether it's something as simple as, supply chain management or cost accounting or, and measuring value that way, or actually how care is delivered and the whole care process and patient process management in a way that is where you can ultimately achieve both quality and value, or value from an economic standpoint. And that equates to kind of this collective idea of value and what we're talking about.
Correct. I think you and I kind of make up the two sides, if you will, of healthcare delivery that have actually been unfortunately separated over the years. So the finance people were over there on the supply chain side, over there in the accounting department, looking at budgets, looking at costs, looking at expenses, And we, the providers, were out there on the front lines of healthcare with delivering care and, quite honestly, not paying much, if any, attention at all to the cost side of the equation, but, again, trying to drive quality. And for far too many of us, the cost piece of the equation didn't even come into consideration. It was whatever we think is good for the patient or whatever the patient wants. We'll order it, we'll do it, and cost is out the window. And again, the system just cannot tolerate that, nor, quite honestly, I think most of us, if we're honest, would say, is that a good way to practice medicine? Because, again, just because you're providing more of services doesn't mean that the quality is going to go
That's
up.
right, yeah. I think that makes a lot of sense. So let me, I guess, putting my hat on as a finance guy again, help me, or maybe give me your insights about where do you think we are in terms of what's it doesn't have to be the single greatest, but if, for all the hospital executives and physician leaders that you meet with, speak with, and work with day in, day out, what do you think is the top challenges, or kind of in that list of top challenges that they're facing today?
So again, to look at this whole thing on a really high level, which we're doing today, what is actually happening, at least in my mind, is we're switching from one business model to another. So the business model historically has been, again, produce a high volume of services. And most of those services are acute, episodic care delivery. So do more surgeries, put more people in the hospital, order more tests, see more patients in the outpatient setting, etc. And in the future, the business model is going to be not producing high volume, but producing high value. Produce reliably high quality outcomes, a satisfactory patient experience, and do that at a reasonable cost. And just like in a manufacturing setting, if you're switching from, producing washing machines to producing air conditioners, you're going to have a different production line, if you will. And what the biggest obstacle I see is, how do you transition the actual production line, the care delivery system, from producing what it has produced now for decades to producing a totally different product? How do you retool that, and how do you jump from one business model to another without falling into a gap in between where everything kind of collapses?
Well, and it's why I typically will say that this shift is very much an evolution. And when you think about all those different components, like you referred to or alluded to, that do have to kind of be a part of that shift, because you can't have just the physicians and the clinical providers driving it, and the folks on the business side kind of holding back the reins on it. And I think it's safe to say the business folks and the finance people really can only do so much to drive clinical behavior, because frankly, that's not what they should be doing. And we don't want them doing that. And there has to be a balance there. So, I guess that brings me to another question as to where do you think we are kind of in this evolution at this point?
So I think, and it's interesting, because when I first joined Coker Group 5 years ago, I really thought the tipping point had been reached. Value-based care delivery was going to be the thing of the future, and most of my consulting work was going to be working with systems to make that transition. Fortunately or unfortunately, at least to me, that wasn't the case. And I've spent really the last 5 years waiting for that transition to really happen. Now I think it has. And I think what's really precipitated it is the whole incentivization of moving to a value-based care delivery model from the payer side. So you've got payers like CMS coming out with MACRA and the quality payment programs that are part of MACRA, which for all intents and purposes are value-based reimbursements. And CMS being the largest payer in the world, you don't ignore that, or if you do, you do at your own peril. And then you've got CMS also coming out with more bundled payments, another type of value-based reimbursement. And then, as usually happens, where CMS goes, commercial payers follow. So not only is CMS rapidly moving down the value-based reimbursement line, Aetna, Cigna, Humana, Blue Cross Blue Shield, etc., are following suit. So I think it's finally happening. It's happening at a very rapid pace right now. And I think we're almost to the point where for a lot of naysayers that said, this won't happen, we don't have to worry about this too will pass, the moment has come when it's really going to occur.
Yeah, that makes a lot of sense. And I want to take an opportunity here. I alluded to this in the intro, but I want to reiterate it here that the listeners, probably hear us cover some broad topics here today in this episode where we'll tee up some things where we could go on and talk about these and many others in much more detail. And we want to do that. So as I said before, this is going to be a series. So please just bear with us as we may kind of seem to skim over some issues, but I promise we'll come back around and drill down to much more detail. But it's a great point talking about the payers and their role because, I mentioned the administration, business side of things and the provider side of things, but obviously the payers are a big piece to that, and they're going to be a variable. They're going to be a stakeholder no matter what. I think it's still shaping up in terms of exactly how their role, how their different structures could ultimately look. But there's a lot of other things that play into this as well. I think about, the back end support to make this shift ultimately work, to make it, just put it in place, but then to truly make it work and to show compelling value over time. One of those that jumps out in all of our discussions seems like that we have on this is technology and the role technology plays in not only effectuating kind of a value-based model, but, making it work long term so that it's scalable, it's dynamic enough to continue to absorb the ongoing changes and those things. We'll just talk about that a little bit in terms of the role of technology, if you can.
Well, I couldn't agree with you more. That component is absolutely key. And if, again, you go back 20, 30 years ago and look at previous attempts at driving down cost and increasing quality in healthcare, one of the missing pieces was we did not have the technology available to actually measure those components. So 30 years ago, the electronic medical record was a very, very nascent industry. Quality measurement was almost non-existent. Nobody really knew how to do it. Nobody could agree on the standards or metrics to use to measure quality. And dare I say, cost accounting or cost measurement was even worse. Healthcare has never been very good at measuring costs. So you were trying to change something that you couldn't really measure. And as Edward Deming said, you can't change what you can't measure. And so I think we've come a long ways in the last 30 years or so. I think we now have the technology to support a lot of this. Are our measurements perfect? No. Are we still a long ways to go in terms of being able to meticulously measure outcomes on the quality side and costs on the finance side? Yes, we are, but we're a lot closer than we used to be. And so IT systems to measure those sort of things in an automated fashion, and then even more importantly, push those data points out to the managers and providers so that they can be used to drive improvements in care delivery is another thing that I think we've been able to move along greatly with the advent of things like mobile technology and smartphones and tablets and those sort of things that can allow us to communicate data much more freely and effectively than we could in the past.
Yeah, I mean, you think about whether you're talking, when we talk about technology and healthcare IT, it oftentimes goes back to the electronic health record, right? I mean, that's kind of where people's minds go to first, I think. But it also relates to the hospital management system, the practice management system, the clinical systems, the hospital financial management systems, ties into the rev cycle, obviously, but also on the cost management side as well. And it's not just big health systems that are doing those types of exploring kind of those options and opportunities in those areas as well. But as much as the technology is great in terms of what the systems can do. I mean, there's all kinds of data, but I feel like we're at this point now where we're able to start making it meaningful or translating the data into value. I mean, we've been able to mine data for years, ever since the EHRs came online. But now, taking that, as you said, or kind of alluded to, translating that into some measurable metrics or, things that we can truly gauge and follow over a period of time. I've said on the physician compensation side, for instance, when we're developing comp models for physicians, there's a portion of it that typically is attributed to quality-based metrics. And I've never come across anything in terms of a quality incentive where that it wasn't something that the physician wasn't already doing, right? Would you agree? I mean, probably a lot of this isn't necessarily making them do things they weren't doing from a quality standpoint. Maybe they're doing it a little differently or they're coming at it from a little bit different angle, but the focus on care has always been there. Now we're just able to kind of measure it, maybe quantify it even, and then we can tie that to some sort of value metric.
Well, I think that's the key is that, I think most of us, myself included, always felt that we were delivering high quality. There are very, very few providers that would tell you, well, no, my quality is substandard. But the surprising thing is when we started to measure it, most of us were wrong. We weren't reliably delivering high quality. Let me give you a real simple example. So, 10, 15 years ago, we decided we started to measure how reliably do we give an aspirin tablet to somebody who presents to the hospital having a heart attack. Well, my now 30-year-old kids, but back then teenage kids, could have told you you're supposed to take an aspirin if you're having a heart attack just from watching aspirin commercials on television. But you go to, at that time, any hospital in the country and measure that, and only about half the time were we compliant with that recommendation. Very, very simple thing. So again, we all thought that we were perfect in terms of doing the right things at the right time that were recommended. But some of the most simple things that you don't have to be an expert clinician to know to do, we weren't doing very reliably. There was no real standardized process for making sure those things occurred.
So that's an interesting perspective, though, because that tells me that the focus on, whether you want to call it efficiency or just focus on more value-based metrics, can drive improved clinical behavior, clinical quality, even maybe outcomes. Not to say that physicians and the providers weren't doing a good job, just, again, maybe kind of the way they were doing it or certainly the way it was being managed.
Yeah, exactly. And there's all kinds of incentives or disincentives or perverse incentives even in the system. I can remember again, 10, 15 years ago, as I'm practicing as a hospitalist, I'm probably as likely to prescribe an antibiotic for somebody in the hospital with pneumonia because of the drug rep that brought me a free lunch the day before and what they are asking me to prescribe as I am to do it according to the literature and what the science says is the best to prescribe. Again, lots of incentives and perverse incentives out there to do things, and we all like to say we practice by evidence-based medicine standards, but the truth of the matter is, again, when you look at it, we don't do that on a regular basis and, again, fall short way too often. So the good thing about value-based reimbursements is that now you get reimbursed based on how reliably you do follow those standards and those and produce those quality metrics. One could argue, well, you should have been doing that all along, and I agree, but the truth of the matter is the fee-for-service system wasn't really rewarding that, so a lot of people were ignoring it.
Yeah. I mean, that it definitely is going to drive behavior, and the way it's been driven in the past is well, different to say the least. But one of the things I want to talk about is something. Well, I want to touch on something you talk about. Really, I feel like you have developed a model here that has become very meaningful for really any size provider-based organization, healthcare services organization. But I've heard different terms on this. I've heard, clinical process management, patient process management. But I think it all kind of wraps up in this idea of care process design. And I know this is something you've really spent a lot of time thinking about, developing, and now doing. Just tell us a little bit about what is care process design and how does it kind of tie into all this stuff?
If you think about, again, moving towards a more value-based care delivery system, at some point, it's a lot more than simply accepting contracts with payers that pay for quality, pay for outcomes. It's a lot more than simply having the IT systems to measure quality and cost. What has to happen is the care delivery at the bedside or in the exam room or in the OR actually has to change. Patterns of practice that sometimes have been embedded into the system over decades have to change. And the way you do that, at least in my opinion, is you have to have a systematic method to, number one, understand how those care processes work now, and number two, design a way for them to work better in the future, and then to measure those outcomes and to continue to refine that care process over time via an iterative change process. And that, to me, is what I call the care process design system. It involves mapping care processes. It involves applying best practices and evidence-based standards to those care processes. It involves cost accounting each of those steps in the care process so you understand how much it costs to deliver that care. And it involves measuring outcomes, both quality and cost, and feeding that back to the care process design team so they can refine it and iterate the process over time. And again, that's not the way it's traditionally been done. The way that we deliver medicine today is basically done on the basis of, well, that's the way we've always done it, or that's the way I was taught to do it in residency, or that's the way old Dr. So-and-so used to do it, so he thought it worked good, so I started doing it that way. And it's just not very scientific. It's not very systematic. And again, that's you've really hit the nail on the head, in my opinion, in terms of something that absolutely has to change if we're going to retool the system so it delivers higher value care.
Right, and there's an operational component there as well, meaning, the technology systems that not only support the process, but have the analytics and the metrics backing it up and driving it and continuing to support it and kind of generate value from it. You got to have the financial elements there, which you kind of touched on. Cost accounting is one, but there are kind of multiple angles there, and many other things as well.
It's interesting. I just want to interject here. You said the systems to support this, and that is exactly what has to happen. So the quickest way to get things thrown at you or run out of a room is to go to a group of doctors and tell them, okay, here's the protocol for, I don't care, treating pneumonia, treating diabetes, taking out a gallbladder. Here's the protocol you all have to follow, and you all have to do it the same way. They will, you will not last long in that conversation. But if you give providers tools, IT systems, data, analytics, best practice care guidelines, etc., that support them in determining in their own world, in their own facility, with their own patients, with their own background and capabilities, here's the best way to do something. You figure it out, you design it, and you create it. They'll do that all day long.
Well, I think it goes the same. You could say the same for if you try to get them in a room and say, this is the system, this is the solution we've adopted. It can do A, B, and C. Now adjust your behavior around that, as opposed to kind of bringing all stakeholders into that, letting the process drive. Okay, then what system supports the process?
That's exactly right. And if I had to say one big mistake, for instance, with EMR implementation, electronic medical record implementation, that we've made is far too often we've gone in and we've implemented the system, and we've expected the system to then drive the workflows and the utilization of that system, which is totally backwards. We should have gone in, designed the workflow, designed the care processes, and let the EMR support that. And that's led to many, many providers. The other way to get run out of a room real quick is to come in and say, okay, I'm here to help you with your electronic medical record implementations.
Right. Yeah. It's like, what problem do we start fixing first, I guess? I want to cover a couple other things. And again, we'll follow up on a lot of these things and go into more detail. But I feel like we can't have this discussion without at least introducing the role or the role of and the importance of, or the relevancy of, MACRA and kind of how that ties to this whole thing. So maybe just give us a little introduction on MACRA and kind of how it ties into this discussion. And then obviously, again, we're going to have a whole other discussion on specifically MACRA and kind of what systems are doing, what can be done, what are some of the issues, challenges, those types of things. So, but I do want to at least touch on it.
So MACRA, again, quite simply, is a brand new way of paying providers, physicians, advanced practice providers, dentists, other clinicians that work under Medicare reimbursements. It's a different way of paying them than the traditional fee-for-service model. MACRA is pay for performance or pay for value or fee for value as opposed to fee for service. And again, because CMS is the biggest payer in the country, it's going to be earth-shattering when this is fully implemented in January of 2019. If you start being paid on the physician side or on the provider side for performance by the biggest payer out there, soon all the other payers out there will follow suit, and the way that providers get paid will drastically change. But again, as I just said, the trick is going to be how do you react to that? It's not just, okay, I understand it. I've read the rules and I know how to report my data, but do you know how to operate successfully under that model? Do you know how to move the dial on those metrics? Do you know how to make sure that you're getting paid the highest amounts because your performance is higher? Do you know how to make your performance higher? That's, I think, where we're at in terms of, provider understanding and preparation for this.
Do you think MACRA's, which, by the way, just to clarify, so MACRA is the kind of policy-driven model for kind of going this direction in terms of pay for value. Do you think it's on the right track?
I do. Just to kind of give a personal aside, I practiced medicine for, maybe 15 years or so, and really woke up one day and realized, this just, I'm in a system, I'm working in a system that's really not rewarding me for what I consider the motivating factors that drove me into a healthcare career in the first place. As I like to say, when I went to my interview for medical school and they said, why do you want to be a doctor? I said, because I like science and I want to help people. 15, 20 years later, I didn't see science being applied very reliably to healthcare delivery. We weren't doing anything or much of anything based on scientific evidence. And unfortunately, we weren't helping a lot of people. We were running a lot of people through the system. We were ordering a lot of tests. We were prescribing a lot of medicine. We were doing a lot of procedures, but we weren't really helping everybody, at least in a measurable basis. So, I applaud the move of payers like CMS towards a more value-based system. Do I understand for many, many providers, it's a hard switch to make. It's a hard transition to go through. Absolutely. I mean, you do anything long enough and you get very comfortable with it, and it could be as perverse and drive misincentives as much as the fee-for-service system does, but it's what you know. So, you stick with it. And it's going to be tough to get through the transition, but I think in the end, the patient will benefit, and I think providers will find practicing medicine and delivering healthcare will be a lot more satisfactory.
Yeah, I think it'll be one of the first big opportunities in terms of realization of the impact, and I mean impact from many different angles or multiple different angles, because and again, we're going to have a separate discussion specifically on MACRA. So we'll really dive in deeper. But, I think it's interesting that because we're talking about how value-based healthcare requires all these different things, all these different components and elements of the system to a certain degree come together, but certainly to work well, kind of is in its own, in this kind of new dynamic. But I think it's interesting that I could walk into any hospital CFO's office in the country, and they should most likely will be able to tell me kind of the financial impact of MACRA today. For many, they're at that point of they're just kind of accepting the penalties, right? Because it's maybe not as significant, or it's still new enough to where they're trying to digest it and figure it out still, so that they can figure out what to do in the future with it. But my point is always said, and they certainly, this is no shocker to them, that, your boards, your administration, and your management, they're only going to allow those losses or penalties to go from non-compliance with this program for so long, right? Especially when compliance is an option. It may not be an easy option. It may not even be a simple option, but it's to a certain degree becoming the new norm. And it will continue to be so. And so, when there's millions of dollars being impacted to an organization because of this, they're only going to be able to, not that they're ignoring it now, but they're only going to be able to put it off for so long, I think.
Well, absolutely. The penalties start next year in January at 4%. And, maybe really large systems can tolerate that. But then it goes to 5, then it goes to 7, then it goes to 9. And before long, as they say, you're talking about real money. And it's interesting. We do a variety of sizes of organizations. And even the smallest organization, by the time you get to that 9% level, you are talking about millions of dollars at risk. And so it's enough to drive change, and it should be, because the changes are not going to be easy. A lot of providers are still hoping that somebody's going to ride over the horizon, the cavalry's going to come to the rescue and make this all go away. But the truth of the matter is, if you look at MACRA, for instance, it was passed in 2015 as a piece of legislation, and it was passed with overwhelmingly bipartisan support. So whether you're blue or red, Democrat, Republican, whether you think Obamacare it needs to go, MACRA is probably, in my opinion, here to stay, because, again, it's a solution to the fact that, it is untenable for us to go on with healthcare inflation outstripping, the CPI by 2 or 3% every year, and us not having the quality to show for all the money that we spend in healthcare.
Yeah, I know. I've always I closely follow kind of healthcare policy developments very closely, as you do as well. And I think that's a whole other discussion or element of this discussion as well. But we tend to hone in on the Affordable Care Act and kind of what's going to happen with that, and how's Obamacare provisions, or how are they affecting payers and this year and next year. But all the discussion in the world about the politics and the impact that Washington has on this, still, this is here to stay. I mean, as it relates to MACRA, and even if it's a few years from now, and maybe it's a different iteration of MACRA or something like that. But I think your point is, this model is here, and it's only going to continue to be more pervasive.
Absolutely. Yeah. I think, if you look at the ACA is predominantly a piece of legislation to expand access to care and more particularly access to health insurance. MACRA is, again, a piece of legislation designed more specifically to solve this value conundrum, which is, in this country, we're unfortunately amongst economically developed countries around the world in last place in terms of value delivery. We spend almost twice as much on per capita on healthcare as any other economically developed country in the world. And in most measurements of health, population health, infant mortality, longevity, etc., we are last. And so, it's just not tenable for us to go on like that. And MACRA is the legislation that was passed to change that. Will it get modified? Absolutely. It already has in many ways, and there'll be allowances made for some of the features of MACRA that are particularly onerous, but it's not going to go away, in my opinion, or anybody's opinion that I really trust.
Yeah, I agree. It's funny, we've had this whole discussion, and we haven't even touched on. You mentioned population health, but the concept of population health management, of course, I think that ties back into your concept of care process design. Obviously, we hadn't touched even on ACOs and kind of the evolution of those in and of itself is kind of its own topic. But so we absolutely will, again, kind of circle back on some of these things. Before we close out, I just want to get one of a recent development that I thought was real interesting, and I just wanted to get your kind of quick read on or take on is we're seeing kind of some newer, maybe a little bit unique consolidation trends happening. So you've seen the CVS deal with Aetna, Cigna and Express Scripts, Walmart and their deal with Humana. That's, kind of still, and then one of the most recent things we've heard about is this kind of what I call, I don't know if it's just Silicon Valley, but it's certainly, some key players from that world, from the financial world. You got Amazon, Warren Buffett, Berkshire Hathaway, JP Morgan kind of coming together to try to, I'm not sure anybody's completely certain what they're doing or trying to do, but you start hearing, you look at names like Walmart and Amazon and Warren Buffett and JP Morgan Chase and CVS, and something's happening, obviously. It's big. There's significant billions and billions of dollars tied to it. What's your read on that?
So I tend to be a big picture guy. When I see things like that happening, I try to fit them into the big picture. And to me, the big picture that those things that you just mentioned, whether it's consolidation, new delivery models, or even, an attempt by Amazon and Berkshire and others to, kind of do an end around the third-party payer and directly contract with providers. What I think you're seeing is basically a frustration with the consumer of healthcare, whether those are large employers or even individuals, and saying we're not getting the value that we deserve. And in fact, the value is declining because year after year after year, our premiums go up, our deductibles go up with consumer-directed healthcare plans, our copays go up, and the access to care that we get, personalized, patient-centered care that we receive seems to be getting worse. And I think what CVS and others realize is, okay, if the providers won't change, we'll go in and we'll create disruptive innovations. Retail medicine, CVS Minute Clinics are an example of that. If the providers won't give patients access to care when they need it, for what they need it at a reasonable cost, we'll step in and provide that innovation. On the payer side, Berkshire and JP Morgan and Amazon are saying, look, if the payers won't, decrease cost, we'll cut out the payers. We'll cut out the third-party payers, and we'll develop systems. And you're right, nobody knows exactly what they're developing. In my mind, they're saying the insurance companies aren't driving value into the system, so who needs them? We'll figure it out ourselves. And that's the big picture, I think, that's playing out there.
Yeah, I think I'm kind of a big picture guy too, like you, and the overarching message to me right now is that, well, we know there's not one technology that can be your silver bullet to solve problems. There's not even one process that works for every organization or one model. But the idea is that as reluctant as the healthcare industry has been to embrace innovation in the past, we're to that point now where innovation is truly kind of an answer to areas of need. And it's not just fluff, it's not just flashiness and aesthetics, but it truly is kind of bringing the stakeholders together. As cheesy as that sounds, ultimately that's where it has to start, I think.
Yeah. I'm a hospitalist, or was a hospitalist when I was still doing clinical practice. And, for 2/3 of my professional lifetime, there was no such thing as a hospitalist. And then somebody came up with the concept, and now you hardly go into any hospital of any size in the country that doesn't use hospitalists to manage their inpatients. It's amazing how some of these disruptive innovations can catch on and become standard ways to deliver care. And I think that's what we're seeing with a lot of these things that are happening, not only in the clinical space, but in the payer space, in the business space, and the consolidation of different types of providers, and in businesses that aren't even really considered healthcare providers getting into healthcare. So.
I completely agree. This has been extremely beneficial. I want to bring it kind of to a close or a full circle here, but last thing I want to do with you, one of the things we say and maintain, the idea of this content and this forum, if you will, is not just for us to come on and do nothing else but promote Coker services. But I do want to give you an opportunity to tie that into the discussion, because I do like at least having some potential takeaways or action items that can come out of a discussion like this. So just, if you don't mind, give us kind of the 2-minute spiel on, what are some of our services and some of the things you're doing today with clients that relate to some of these topics.
So we have a suite of services at Coker Group that we've actually trademarked and call Value Path services. And as the name implies, it is a number of services that are designed to smooth the transition from volume to value, to make going from that one business model to the next less risky, easier, seamless, and not let you, no matter if you're a physician practice or a hospital or healthcare system, fall through the gap that's in between. What do our value path services entail? Well, it can be everything from, again, helping you choose, select, and implement IT systems that help you deliver higher value healthcare. It can be services to help you design your care processes, the care process design system that I talked about earlier, to actually retool the clinical care at the bedside or in the exam room. It can be services to incentivize your physicians to practice in a more value-based care fashion. So compensation models that include incentives for quality and cost efficiency. It can be retooling your revenue cycle in your physician practice, so that you know how to invoice for services. Do you know how to invoice for value-based reimbursements and report your data, report your quality metrics, report your cost, to be sure that you get fair credit for the work that you've done for your performance. So lots of different things. We've really got the gamut of services in all our 4 service lines to really cover each of those. I'm excited because I think if we get through this kind of tumultuous time, I think healthcare in this country is going to be markedly improved. And quite honestly, I wouldn't be doing what I'm doing if I didn't think that was kind of the overarching purpose, as opposed to just, selling consulting services.
Absolutely. I certainly second that, and I don't think you could have said it better. And again, I look forward to some of the follow-up discussions. I mean, I already know I'd like to talk more in depth with you about macro, helping systems navigate that transition, preparing for it, but then, ideally optimizing it as that continues to evolve and grow and become more of the norm. I'd like to talk about how that connects to some of the other policy-driven activities that we see, whether it's the ACA or whatever happens with that, and kind of this, as we go into the election season later this year, I think that will only continue to change. And again, that's going to affect whether it's directly macro or other ways that these policies are affecting provider organizations. And then, on the technology side, I know you've worked with a number of different technologies that go way beyond the EHR, truly get into what are other ways to capture and report on value, as opposed to kind of the old legacy model, and many other things too. I'd like to talk about how this affects rural health facilities, because we know the majority of care in this country is really provided in that setting to a certain degree. However you define rural health, maybe that's a little too specific, but meaning it's not all done urban-based acute care, and so I think that's a whole discussion, because those organizations are sometimes facing different problems or sometimes facing more acute problems or challenges as it relates to this type of thing. So I'm glad you did that. I really appreciate you taking the time, and I genuinely am looking forward to this follow-up conversation. So I appreciate it. As we close here, I do want to mention again, as we mentioned in the first episode, one of the things we really want to emphasize in this podcast is we want your interaction and your feedback and participation. So we absolutely welcome feedback from our listeners. We would love for you to tell us what you think about, what we're talking about. And if you have a different take, please send that to us. We will absolutely review it and address it, and maybe it can tee up kind of further conversation. Also, let us know if we miss something, or if there's something you want to hear us cover, whether it's this specific issue and you want us to go into more detail on some component of this or something else completely. You'll find as we get through these podcast episodes and cover different topics, we can cover from certain angles. But if you guys, if there's something that you'd like to hear more about, or have us talk about something completely different, then we'd love to get that feedback. So please send that to us. You can find Coker. One of the best places to start is our website, cokergroup.com. Also, a great place to find us is on Twitter and social media. At Coker Group is our Twitter page. You can go to LinkedIn and find a lot of other good content if you go to LinkedIn and search for Coker Group and find our page there. Also, if you do have some feedback or questions or suggestions, feedback@cokergroup.com. Send us an email there. That's feedback@cokergroup.com. And we absolutely will respond to everything and incorporate into future discussions as well. Also, I'll mention real quick, we will have a post on our site for this episode where you can find show notes, additional commentary perhaps from Mac, but also some links to references for other materials. For instance, I know, Mac, you've written a number of articles and white papers on this topic and other kind of topics related to value-based healthcare. And so we'll make sure to provide links to those items, as well as, kind of anything else. Maybe I know, Mac, you speak a lot on panels and conferences and those types of things. So if there's any relevant links there, I want to make sure people can find you and your social media contacts and things like that. So again, thank you for participating. We would thank everybody for listening. Please send us your feedback, and we'll look forward to talking to you on the next episode.
Thank you for having me. Enjoyed it.